The White Conference gets better every year, and one of its unique characteristics is its huge success in attracting people from different disciplines, and this session is a very good example of that. Instead of having all the IS people up here, we have two economists and one public policy scholar. So without wasting any more time, I would ask Sunita Desai to start her presentation.
Thank you. So interoperability refers to providers' capability to electronically exchange patient medical records with other providers and to use the information in those records without additional manipulation by the recipient. So in this study, I investigate how two defining characteristics of interoperability affect adoption of interoperable IT systems. The first is that interoperability forms an information sharing network. And as in any network, it's only valuable for a given provider to join if there are other participants already in it. So this is the network effect, and specifically, the network effect refers to the increasing value of joining a network in the number of other participants. The second characteristic is that interoperability involves the sharing of patient records. And patient records may be a competitive asset for providers. And as a result, some providers may be reluctant to engage in information sharing with other providers, some of whom may be their competitors. So I call this information blocking, which is also a term that's being used by policymakers to refer to this type of behavior. So I think it's important to study the factors that encourage and discourage adoption of interoperable IT systems for a couple of reasons. So first, the ability to seamlessly exchange information between providers has a potential to improve costs and quality of care. Acknowledging this, the federal government passed the HITECH Act, in which it invested over $30 billion to promote adoption of electronic health records, health information exchange, and a culminating goal of HITECH is interoperability. So while HITECH has been considered successful in spurring adoption of more basic IT capabilities, as we've begun to focus on more advanced IT capabilities such as information sharing and interoperability, the efforts have largely faltered. And then finally, as I alluded to before, recently there's been a lot of evidence or allegations of information blocking behavior. And just to clarify, the term information blocking is often used interchangeably to refer to providers and vendors. In this work, it refers to provider behavior, although vendor-level information blocking will figure into my policy implications, which I'll discuss at the end. So there hasn't been much empirical work on interoperability, and so it's difficult to ascertain the exact extent of interoperability currently. Interoperability is a little bit tricky to study empirically because it's not just a technology that a hospital adopts or doesn't adopt. Instead, it's more a characterization of the relationship between multiple IT systems. So I attempt to address this gap in the literature by devising a way to measure interoperability or the capability to be interoperable. So I exploit the fact that in general, at least in the current state of technology, interoperability is largely limited to same vendor IT systems. So I use this and I assume it more broadly so that I can define hospitals as being interoperable or having the option of being interoperable if they have adopted the same vendor's IT system. So with that in mind, I have two empirical research questions. The first is, do hospitals value interoperability? So if interoperability is limited to same vendor systems and hospitals do value interoperability, then we should see network effects in hospitals' vendor choice. And the second question is, do some hospitals engage in information blocking? So I test this by testing whether hospitals that we expect to be vulnerable to losing market share demonstrate negative value for interoperability. For this analysis, I used two related data sets. The first is a national hospital-level panel dataset from years 2009 to 2012. And the key variable here is hospitals' vendor choice. And I focus on vendor choice for clinical data repository software because that is the capability that's most closely related to information sharing. In the second analysis, I incorporate some hospital-level data on the patient population seen by the hospital. I aggregate this data from the states of California, New York, Florida inpatient databases, and so this analysis is limited to hospitals in those states. Okay, so the first question is, do hospitals value interoperability? So hospitals are choosing between multiple vendors, and they'll adopt the vendor that's most profitable to adopt. And profitability from adopting a vendor is determined by vendor characteristics, hospital characteristics, and potentially the installed base, or the market adoption rate for the given vendor. So if hospitals value interoperability, then they will place weight on installed base of a vendor when choosing a vendor. And so in this profit function, if hospitals value interoperability, then beta will be positive. And this would also be indicative of network effects in vendor choice. So I adapt the profit function to a multinomial logit estimation model. So the dependent variable is the vendor that hospital I, is whether or not hospital I adopts vendor J. And the explanatory variable of interest is the installed base for vendor J in the market. And of course, in calculating the installed base, I exclude hospital I, but I also exclude all hospitals from hospital I's system so that I'm not overestimating the network effect because of some within-system correlation in adoption. So, and then I also include some hospital characteristics and vendor fixed effects. Because I don't have other vendor characteristics, I put in vendor fixed effects. So here, if beta 1 is positive and statistically significant, then we have evidence that hospitals value interoperability, or we have evidence of network effects in vendor choice. Because we might be concerned about potential endogeneity affecting adoption behavior by hospital I as well as other hospitals in hospital I's system, I instrument for installed base using adoption rates from hospitals outside of the market, but within the system of hospitals represented in the installed base. And so, since the second stage is nonlinear, I run a two-stage residual inclusion model. So the results from this analysis indicate that hospitals do show value for interoperability, or we do see network effects in vendor choice. So in these results, the first two columns are the multinomial logit results, and the third column is the two-stage residual inclusion, and the fourth column is the first stage. So you can see that across the board, the installed base coefficients are positive and statistically significant. And to interpret these multinomial logit coefficients, taking column 3, we can say that if the probability of adopting a vendor is 0.5, then a 10% increase in the adoption rate of a given vendor leads to a 1.5% increase in the likelihood of a hospital adopting the vendor. And so we can see that while hospitals do put weight on the installed base, it seems like they're placing more weight on other factors when deciding to which vendor to adopt. Okay. So the second question is, do some hospitals engage in information blocking? So I want to define hospitals that we would expect to potentially information block. So my measure for vulnerability to losing market share is the fraction of patients that go to hospital I and go to another hospital in a given year. So if a hospital has a higher portion of patients visiting another hospital in a given year, then I say they're more vulnerable to losing patients. So I interact this measure of vulnerability to losing market share with the installed base measure. And then I run pretty much the same specification. And so here, if beta 1, the coefficient on the interaction, is negative, then we would have evidence of information blocking. So we would be able to say that hospitals that are more vulnerable to losing market share are less likely to adopt a vendor that is prominent in the market. These are the results of that analysis, and they indicate evidence of information blocking. So you can see that the coefficients on the interaction are positive and statistically significant, are negative and statistically significant. And so this is saying that as a hospital's portion of shared patients or vulnerability to losing market share increases, they're less likely to adopt a prominent vendor. So if we take column 2 and we can interpret this as if the probability of adopting a vendor is 0.5 and a hospital shares 16% of its patient population, which is the sample average, then a 10% increase in market adoption rate of a vendor would lead to a 1.1% decrease in probability of adopting a given vendor. So I think this is a stark finding, especially because these hospitals that have patients that are visiting other hospitals are precisely the ones whose patients would benefit the most from interoperability. But here, we're seeing that they're less likely to adopt interoperable IT systems. So in summary, I find evidence of modest network effects, and I also find evidence of information blocking among hospitals who share patients. So I think these findings illuminate 2 reasons why we might be seeing low rates of interoperability. First, while hospitals appear to value interoperability, it's lower on their priority list. So they care more about other characteristics when deciding which vendor to adopt. So when we have modest network effects, it can lead to splintering, which is essentially the formation of multiple information sharing networks with a couple hospitals in each that can't talk to each other, thus defeating the purpose of information blocking. To address this, policies should focus on emancipating interoperability from vendor control. And I think there's 2 broad strategies to address this. So the first would be the government or some industry group creates a common technical standard and mandates that vendors have to adhere to that. So there have been many attempts at this, and they haven't really been successful at getting off of the ground. But I think that even if such a standard was effectively enforced, there are reasons we should be wary of it. Because generally, when a standard is set, it isn't updated to keep up with changes in technology. And so such a standard would inhibit innovation, reward organizations that don't innovate. And especially in a rapidly advancing industry such as health IT, I think that could be harmful. And so I think policies should focus on enabling the entry of third-party developers to offer adapters that hospitals can adopt and be interoperable with other hospitals regardless of their vendor. So examples of policies could be policies that bar contractual clauses that allow vendors to hold patient data hostage, or policies that encourage intellectual property sharing between vendors and developers for these purposes. And so such a market-oriented solution would not inhibit incentives to innovate, since vendors could continue to innovate and the developers of these adapters would have market forces to incentivize them to innovate also. The second reason why rates of interoperability may be low are information blocking. And it's unlikely that the meaningful use payments are large enough to overcome the concerns of these hospitals about losing market share. I think other reforms that encourage alternative models of care can help to reduce incentives to information blocks. So for example, accountable care organizations and patient-centered medical homes encourage care coordination. So I don't think that they can be a panacea because competition between providers are likely to persist, and at the least competition between ACOs is likely to exist, but I think they can help. So in conclusion, interoperability is an important capability. It's important to realizing the full value of IT. In this work, I've shown that hospitals show modest value for interoperability and that some hospitals engage in information blocking. And these findings help to explain why rates of interoperability may be low and policy efforts should focus on reducing provider incentives to information block and free interoperability from vendor control. Thank you.
Colin, yes.
Yeah, if I could use this mic, it would allow me to lazily consult my notes. And if I say something incorrect, Sunita can kick me under the table. Nothing. Thanks very much. My name's Colin Baker. I'm a health economist at ASPE at HHS, and very much a dilettante on the subject of health information systems, the economics of it. So compared to most of the people in the room, so bear with me if I seem silly to you. But anyway, this is a delightful topic, the subject of encouraging interoperability in health information systems, replete with externalities. It's a perfect public policy conundrum. We think that health IT systems show positive network externalities, and so, since individuals can't capture the benefits of it, we expect markets to underproduce them. If I'm an IT vendor, once I've got my bulk of consumers and others buying my product, I'd like to differentiate my product from others, make it incompatible to capture some of my customers. That's a strong incentive that I face if I'm a dominant IT vendor, and it's not necessarily something that leads to a social optimum. The other issue about it is that healthcare providers are interested in keeping patients in their networks, and one way they can do that is to make their health information systems incompatible with others, so as to keep their patient networks whole and make it harder for patients to switch to others. And that's where this paper comes in. This is a great interest at the department today at HHS. The Office of the National Coordinator is very interested in this subject, and there are very few papers on it, and this is a real contribution. I think it'll be very helpful. So basically, three questions asked here. The first, do hospitals value interoperability? And the paper looks at it, examining vendor choice. A couple of thoughts here. First of all, the paper very sensibly defines interoperability as having the same IT vendor, which has the great benefit of it being very correct. I mean, certainly that's interoperable if it's the same vendor. I don't know how to do this, but I like to suggest for the future that we sort of think of some sort of an index of interoperability, maybe something ranging from 0 to 1, where if it's the same vendor, that's 1. If it's completely incompatible, it's a 0. And then on the basis of input from people who know a lot more about this than I do, some sort of degree of interoperability. There have to be some sorts of IT systems that are reasonably compatible with one another. It'd be interesting if we used a more sophisticated index. Again, I don't want to be the one to have to come up with that, but it would be helpful. The second thing, reading the first of the three, there are three general analyses. Looking at the first one, I kept wanting to see an interaction of your key variable with something like hospital characteristics. Like, for example, hospital size. You do that in the third analysis. You look into different types of hospitals by size. I would expect if the question is how much does a hospital or healthcare system value interoperability, there have to be all sorts of characteristics of hospitals that are easy to see that we can look at how the value would differ. Academic centers would probably have a very different value placed on interoperability. I would look at that separately, or interaction term, or however you like to do it. For-profit hospitals versus others. I thought that the instrument that's used for the installed base is pretty clever. If I had more time, I'd like to get into that, but that was a neat effect. So on the subject, having found modest effects on the whether or not the hospitals value interoperability, I'm thinking maybe that's a result of a coefficient very different for subgroups. I don't know, but maybe that's the case. Maybe it's big for some and small for others. I think it's worth looking at, if the data allow it. The second question on HIEs I'm going to skip because I want to get right to information blocking, which is nearer and dearer to my heart. The third question, how much information blocking is there, basically? Or to be more precise, do more vulnerable hospitals or providers information block more? Or to be even more precise, do they choose the non-predominant IT vendors? Meaning that if I'm choosing one IT system that's compatible with all of my competitors, or I can choose another one that is not, which will help me keep my share of patients. One issue in there I had, this is a hard thing to define, but the variable is defined in the paper as the fraction of shared patients. And if I understand it, it's defined around the hospitals that have had an individual hospitalized at my place and also at one of the competitors. Is that how it is? Okay, so I think that's certainly, that is a measure of vulnerability as you've defined it, but I think it misses a lot. There's what you'd like ideally is some sort of set of covered lives that are captured within your network versus a set of covered lives outside. Again, I don't know how you do that. I don't know if the data are available, or it might be available only in certain regions, but I would think that you're missing a lot of the juice that you want in that variable. But the interesting thing is, with all that said, and I was thinking maybe that's not the right way to define it, your estimate does exactly what you'd expect it to do. So maybe it's a lot better than I thought it was. It seems to work very well. The final question on hospital size, you find results that are not consistent with some of the previous work, which is very interesting. I would return to the question of looking at, say, academic centers versus non-academic. If they're bigger on average than non-academic centers, maybe that's where the explanation is. For-profit versus not-for-profit. Out of time.
Thank you very much.
Sure.
So the next presentation is from Marty Cohen on testing theories of innovation diffusion, analysis of physicians' adoptions of EHR.
So in order to get through this in the allotted time, even though this is a quantitative analysis, most of the quantitative details of my study I've included in a number of backup slides in the slide deck. So anyone who is interested in more of those quantitative details of my data or my results, certainly when you download the slides, you can see all that. Okay, so I was interested in looking at physician EHR adoption from the perspective of several of the leading theories on what drives or constrains the rate of diffusion, the breadth of diffusion of an innovation. So, for example, one theory that the principal driver constraint is differences in the profitability of adoption across potential adopters, different circumstances for different potential adopters, sort of something in particular economists would look at about profitability and the costs and benefits. Second theory I wanted to include was the idea that it's differences in information among potential adopters, would-be adopters. This can be things as basic as awareness of the innovation, but it can also be things like the level of expertise you have to implement the innovation. For something complex like an EHR system, which is so fundamental to how you deliver care, certainly your level of expertise and differences in that is a big deal, and so on. It can also just be your general sense of risk about it. That's sort of another information issue, how much uncertainty you perceive about adoption. And then, particularly the theme of this panel, the idea of network effects. And as we already heard, sort of the idea of network effects in particular that I'm interested in is the idea that the return on adoption increases with the number of adopters. But as we heard in the first paper, that requires interoperability. And the literature on network effects would suggest that if you don't, that you get interoperability typically with IT either from promulgation of formal standards or some early market convergence on a dominant design, like Microsoft for operating systems, and that sort of leads to a dominant design, which becomes de facto interoperability, as everybody has to line up under that dominant design. Certainly, these are not mutually exclusive. There's overlap in this. It's not an all or nothing situation. And in the case of EHR adoption literature, all three of these have been cited as concerns, including among physicians. So my specific research question to look at this is, among small physician-owned practices in the U.S., to what extent is EHR adoption status predicted by the physician's views on each of 5 factors that I could look at in my data? The value of improved information as it relates to adoption, sort of information that would support adoption decisions, the impact of the HITECH Act's financial incentives, the Meaningful Use Program, challenges for a practice in selecting a specific EHR product or vendor, which goes to sort of the network effects issues, the direct financial cost of adoption, and concerns about actually implementing the EHR in the practice. I wanted to focus in particular on small physician-owned practices, which I defined as 10 or fewer physicians, for a couple of reasons. My methodology relies on survey data, and I wanted to make sure that I had survey respondents who were particularly likely to be knowledgeable, to have the institutional knowledge about the adoption decision in their practice. So if I had very large practices with 50 physicians, or practices where they're owned by a large organization like a hospital or an HMO, it's very likely that the adoption decision would have been made at a more distant level, and the individual physician in my survey may not have been very knowledgeable about what drove it. So I'm focusing on the small practices for that reason that were owned by physicians. Also, because this particular population has lagged somewhat in their adoption rates, that makes them particularly relevant to high-tech policies to try and boost adoption. So for my data, my primary data is a 2011 survey, a national survey of physicians run by the CDC. The survey included questions, a series of questions that asked both non-adopters and adopters about different issues they may have considered in their decision on whether to adopt. And it was a gamut of issues, so things like the value of the government certification program for EHRs, the effect of the high-tech financial incentives, both the positive and the negative, but things also that were predating high-tech, the opinion of trusted colleagues and the EHRs that trusted colleagues may have experienced or talked with other colleagues about, concerns about selecting an EHR and challenges, the cost of adoption, both the upfront cost and the annual cost, things like that. I had a pretty good sample size of a little over 1,000 physicians in my defined study population, and a pretty good response rate in the survey of a little over 60%, and so on. So my approach was to take these 19 survey questions on these different possible issues that were considered, and based on a factor analysis and my own judgment, I grouped them into 5 composite scales that reflected the underlying factors that I mentioned in my research questions. So for example, the value of improved information, the impact of the high-tech incentives, the cost of adoption, etc. And then I used logistic regression to test the significance of all 5 of those scales in predicting adoption status among those physicians. I controlled for things like physician specialty and age and practice size and location and so on. For sensitivity analysis, I specified a series of different logistic models that varied on several dimensions. So one dimension was, I used, in one version, I used a simple binary dependent variable that you're either using an EHR at the time or not, just a simple yes-no dependent variable with cross-sectional data for 2011. In a second model type, I tried a 3-category dependent variable with a multinomial model where the possible adoption statuses to predict were that you could be using an EHR, you could be in the process of adoption, or you could be not yet even in the process of adoption at the time. And then third, for a subset of my data, some of those respondents also responded to the survey in the following year, in 2012, and I was able to do a longitudinal model where I looked at physicians who were non-users in 2011 and tried to predict, to see which of these scales were predictive of who shifts to becoming a user in 2012. And then I also varied the models in terms of what population I included in the data. I looked at my full study population in some, and then in some I took out adopters who were predating the high-tech period so that I could focus the models more closely on decisions being made during the high-tech era. So as I said, my detailed quantitative findings are in some backup slides, but just to hit some of the high points. So regarding my variable for the influence of improved information on an adoption decision, physicians who reported improved information as important to their adoption decision turned out to be much less likely to have adopted by 2011. I think that makes sense. If you think about later adopters, they tend to be more cautious. They need more reduction in uncertainty about adoption before they're willing to commit, as I said, especially for something complex like an EHR. And I think my findings consistent with that the laggards were feeling more of an information need, that they needed more information about the effects of adoption and the feasibility and so on. But once I focused on physicians who had either not adopted by 2011 or were on the verge of adoption, in terms of trying to predict that, the information scale was no longer a significant variable. It wasn't statistically significant anymore. it was highly significant when I looked at early adopters versus the later adopters or non-adopters. So I don't have the data to definitively explain that, but one of my conjectures in the paper is that that may be a sign that under the HITECH Act, perhaps some of the information needs and the information gaps among the remaining potential adopters, perhaps those are narrowing from all the multiple mechanisms where HITECH is putting more information out there. But as I said, that would require further research to confirm. Regarding the HITECH financial incentives, my models that isolated decisions in the HITECH period were very consistent in finding that the degree of importance physicians attach to the meaningful use incentives is a very strong predictor of recent adoption. For example, in my two multinomial models, a 1-point increase on this 3-point scale I created for the incentives influence, it increases the likelihood of being a recent adopter relative to remaining a non-adopter by over 300% or more. In one of the models, it was as much as 500%. And also in my longitudinal model, where again I started with non-adopters in 2011 and tried to see which factors predict who becomes an adopter by the following year, only the incentive scale, that was the only one of my scales to be a significant predictor for that. Regarding network effects, as I said, in the absence of interoperability or a dominant design, the literature on network effects would suggest that a lot of the potential adopters would hold off committing to adoption out of concern about which particular version or vendor to select, to commit to, out of fear of obsolescence, or that that'll prove to be the one that isn't going to be interoperable down the road. But in my model, the scale for concerns about selecting a specific vendor or product was not a significant predictor across any of my models at conventional significance levels. And I think that's supported by some other data from a study I looked at by Gold et al. In 2013, where they looked at market share data for the physician EHR market as of late 2012. Over 350 different vendors had sold an EHR to physicians or professionals who were in the meaningful use program by 2012. And the largest single market share among all those vendors was about 20%, and the top 75% of the market share is spread among 16 different vendors. So a very unconcentrated market, and not the sort of behavior that the network effects literature would predict if you've gotten to this level of fairly broad adoption by this point. So some of the limitations in my study, the composite scales I'm relying on for this, they're certainly imperfect measures of these underlying constructs I'm trying to look at. They're somewhat blunt, but I think the scales have good face validity. In one of my backup slides, I list all the specific questions that I grouped under the scales, and I think those generally kind of make sense. And also, one of the conventional measure for how consistent a scale is in measuring a single underlying construct is Cronbach's alpha. All of my scales had very good results for Cronbach's alpha, so again, I sort of felt okay with that. And in particular, I think as long as I'm not overemphasizing the specific sort of percentage impacts from my odds ratios and my risk ratios, I think the scales are useful for providing general comparative indicators of direction and magnitude of effect at least. I already mentioned the risk that some of the respondents might not have enough institutional knowledge about the decision making, but as I said, I tried to mitigate that in how I defined my study population, and also I excluded any responses from the survey where it was an office staff member instead of the actual physician who had completed the survey. Another limitation is clearly I'm not addressing all of the factors that can influence adoption. One of the other major theories, for example, about diffusion is the epidemic model. You're all familiar with, I'm sure. I didn't have the data to really do a test of the epidemic model. And even some of the specific policy issues that might influence adoption, like legal concerns, privacy, data security, that wasn't in my data set where I could really look at that either. So as far as some implications for policymakers, my finding about the influence of the government-imposed financial incentives, I think is indicative that to the extent government in particular is trying to promote other innovations where the business case for physicians adopting may be somewhat weak, that making sure that the promotion program, the policy, has explicit government-imposed sort of financial incentives to improve that business case, I think that's very important. Things like the patient-centered medical home model model come to mind that CMS is doing a lot of work to try and promote right now. My finding on the value of improved information for later adopters rather than early adopters, I think that also has a lot of implications for current government efforts to promote other innovations. So for example, again, CMS really puts a lot of effort and resources into technical assistance when they're putting on demonstrations to test adoption of innovations right now. And so a lot of data sharing, as I said, a lot of technical assistance and that kind of thing. But the fact that that kind of support might be more important to the later adopters, I think raises some real questions about how you scale up when you go national. And one of our presentations this morning talked about that challenge about scaling up from a single pilot to a national program. And then lastly, in terms of network effects, I think that given that we've now sort of reached not certainly total adoption across physicians, but certainly a very high level of broad adoption at this point, although you can question how deep it is, but the fact that we've gotten there without a dominant design at this point means that achieving interoperability is going to be much more difficult. Clearly that's sort of rising on the policy agenda now, and so getting those benefits is going to be more difficult. We're not getting the benefit of the market forces that the network literature, the network effects literature would normally expect. I'll stop there.
Thank you very much. The discussant for this paper is Dong Jill from University of Connecticut.
Just for the record, no, I did not change employment. I'm in University of Cincinnati. So UC and UC, we think alike, I suppose. So,
This is University of Connecticut.
I know. I realize that. First of all, I'd like to thank White for inviting me to be a discussant. It's a pleasure to be here and giving me the opportunity to comment on this particular paper. So first of all, there's a lot to like about this particular paper. So let me, without trying to repeat a lot of things that Marty has mentioned, let me try to highlight some of the things that I found to be interesting that I would like to share with you. First of all, I think Marty, I think about Star Trek. He's chartering places where nobody has chartered before, and because it's underexplored area. And I think it's also timely because he is examining the small physician-owned practices. And so there's not a lot of research in this domain. There's a lot of research around, large-scale hospitals or bigger scale physician offices and whatnot. So I think this is one of his contribution, and he's limiting to less than or equal to 10 physician practices. So again, very small. Another thing is that we've heard a lot today as well. There's a lot of focused around customers, customer view, or even hospital view. But little attention has been discussed around the physician's perspective. So that's, I think, another contribution that he's bringing to the table. So there's a lot of focused around patient-centered programs and the outcomes thereof. So it's interesting to kind of bring the physician's perspective into the picture. And you should read this. I encourage you, all of you to read it because, again, there's a lot to like about this. There is this greater understanding about these facilitators and inhibitors of EHR adoption among small practices that he is examining. So just, again, a little bit of a background. He is introducing this diffusion of innovation theoretical framework to answer his research question. And what's nice about the way he positioned the paper is that he has introduced these elements as the barriers to adoption, and then he goes on to conduct additional literature review in talking about government intervention policies and how they are addressing these very barriers. There's some good synergy in the paper in terms of the flow, and really carries the reader in helping us understand exactly where it's taking the paper. I like the visual aid, so one thing I would have appreciated was some sort of research model. So I took the liberty of doing this. I hope it's accurate. Yeah, that's great. So basically, he has 5 independent variables with 1 dependent variable, as you see there. Okay, so he's interested in the physician's adoption of the EHR along those 5 independent variables. So let me just highlight some of the things that I felt to be pretty important and interesting. He did use this multi-model approach using this 2 cross-sectional National Center for Health Statistics survey data, as he discussed. One of the challenges associated with this is that as I was reading it personally, I got caught up with so many different studies, so many different analyses, that sometimes I would lose focus on how which model really meant with what. So it's possibly focusing on, while the sensitivity analysis is very useful and helpful, maybe reserve that for supplemental slides perhaps, or supplemental notes or appendix, but focus heavily on the key core concepts and maybe 2 different models perhaps. So just one quick suggestion around that. So as mentioned, one of the findings is that this cost continues to be the most important barrier to adoption. Another interesting finding was that, I thought this was very interesting, improved information perceived as influential to their adoption. However, these folks were less likely to adopt. So I'm going to touch upon that a little bit later. And that network externalities is what I'm calling here, is basically suggests that there are these benefits of adopting later,